Welcome to the launch of World Cancer Day 2022. It is amazing what this day has achieved since the year 2000. World Cancer Day can now boast yearly around 840 activities, 700,000 social media posts, 20,000 press mentions, and 152 landmarks illuminated, including Petra in my own beloved home. All these activities happening in one day from almost every corner of the globe. World Cancer Day has become the most amplified and impactful global platform for all cancer patients and advocates. The platform where we can all make noise, lots of noise, reminding all that we can win the war against cancer. We have the knowledge, we have the tools, but we need first and foremost the overarching will, the ironclad moral will that believes at its core that everyone on this earth has the right to benefit from these tools and the right to access care and treatment. The chance to live should not be a question of geography, nor of income, education, nor of discrimination, whether be it based on ethnicity, gender, sexual orientation, age, or disability. Inequity in health is unacceptable in all its forms, either between countries or within countries. And that is why we want to dedicate the next 3 years of World Cancer Day to address inequity front and center in order to close the care gap so that life-saving cancer care services are available for everyone, everywhere. In 2022, we want to realize and internalize the roots and the scale of the problem of inequity, humanize the statistics so that we can truly bear witness to those who are experiencing great suffering. In 2023, we want to unite our voices as together we are stronger and take action. In 2024, we want to challenge those in power. In short, we want to create a global movement that fights for all cancer patients to have equitable access for care and treatment. Actually, today we are very fortunate to have two amazing human beings who can really weigh in on the issue of equity. Professor Paul Farmer, a personal hero of mine. I have to get it out there. He has a CV with so many accolades and academic acronyms, publications, bestseller books written, you name it, too long to mention here. But for me, Dr. Paul's legacy is his lifelong, unrelenting quest, 30 years plus, trying to decode, in his own words, the pathology of inequity in health. The what, the why, and followed most importantly by the how to challenge inequity. And he has done that, not just from the pristine pulpit of his Harvard University desk, but on the ground, in the remote hills of Rwanda, Haiti, Peru, and other countries, listening, understanding, and doing, ultimately co-founding Partners in Health, whose sole DNA is to challenge and deal with inequity. And then we have Philippa Kebugu-Dekwir. Philippa is an amazing human being. I had the honor to meet Philippa in Rwanda 2 years ago when I visited her organization, the Breast Cancer Initiative East Africa. Philippa experienced a personal tragedy, but she did not let that tragedy have the last word. Instead, Philippa spoke, and she spoke loud and took action. Philippa, please tell us about your personal story that led you to start your initiative.
I am a wife, a mother, a grandmother, an educator, a passionate advocate, and a breast cancer survivor. My experience with breast cancer started with the suffering of my sister and the death of my beloved Mabel. Mabel lived in Lumumbashi, Congo, where She did not know anything about breast cancer. She did not have any access to any cancer services or care. Her family airlifted her to London. But when she got there, after an expensive surgery, she passed. She did not survive because her cancer had metastasized into her liver. I had to escort my sister to Lubumbashi, Congo, at 23 over hours in flight. In 1994, I got my own diagnosis, but unlike my sister, I was an informed patient, and I received state-of-the-art treatment by several doctors, care and support. I survived. I lived in America. Now, instead of celebrating my survival, I was haunted by two questions. Would my sister Mabel be alive if she lived in America? Number two, should where one live determine if she lives or dies? I had a major hurdle to fight with. I decided to go and visit my homeland, Rwanda. That is in 2007. The dire status of breast cancer made me realize that I had to do something about it. And what do I do as a teacher? I had to teach. What do I teach? The basic necessity that everybody who is faced with cancer or breast cancer has to have. I had to do breast cancer awareness and education, the necessary component of any program that's going to succeed combating cancer. Now, what do we do? What do I do? I teach breast cancer awareness, breast cancer health, breast health awareness. And I have to empower the people I teach because they're very different from people in the US. I have to fight stigma, myths, and misinformation and traditional beliefs, including religious beliefs. So I set off to, in my own way as a teacher, to teach what is cancer. And I was surrounded by so many evidence-based information which I used. So I teach risk factors, signs and symptoms, importance of seeking early detection, which actually saved my life, though I was in the US. And I have to collaborate with breast cancer survivors, groups in the country, the ministry, policymakers. And the whole thing is surrounded by my strong belief in knowledge being powerful. So I am very excited to be on this panel with the most famous and generous man in Rwanda, Dr. Paul Farmer. And I hope now to meet him in person and get to glean on him. And with this coming World Cancer Day, let's all prioritize awareness and education.
Thank you so much, Philippa. I mean, your story, your personal story literally encapsulates what inequity means when it comes to cancer. Two sisters, same disease, different countries, different opportunities, and different outcome. Inequity is not just some cold academic term. Inequity cost Philippa her beloved sister. Inequity has real consequences. It cost precious lives to so many. And one more thing about your story, and I think this is important for everybody to hear, is that your story also encapsulates World Cancer Day spirit. You do not have to be an oncologist nor an expert to fight cancer. Each one of us has something to contribute in the fight against cancer. Thank you so much, Philippa. Dr. Paul, Professor Paul, we brandish and utilize the word equity quite freely in the world of global health and cancer lingo, without truly understanding what the lack of equity really looks like and feels. And as you say in your books, the experience of suffering is often noted, but it's not effectively conveyed by statistics or graphs, and that the suffering of those who are remote is often less affecting. I know that firsthand as previous director of the King Hussein Cancer Foundation and as a mother of a cancer survivor. I know what it felt like when a statistic becomes alive right in front of you in the form of a little girl with big brown eyes looking questioningly at you as if saying, "Are you going to treat me or are you going to leave me to die?" The tragedy of inequity really hits home up close. It took COVID-19 to equalize the misery experienced by millions of the unfortunate amongst us and to unmask the collective apathy to the very issues that are the daily lot of millions of disadvantaged cancer patients, particularly in poorer and low and middle income countries. Despite great progress in cancer care, many of these patients still to this day die needlessly from diseases that can be prevented, can be vaccinated against, can be screened for, and for which in many cases there is cure. Cervical cancer is the most striking example where widespread screening, early diagnosis, and HPV vaccination could actually lead to its eradication. And yet, decisive action, the same we saw with the coronavirus, and adequate funding are still not as forthcoming. However, having visited Rwanda in 2019, I had the honor to visit Butaro Hospital and the University of Global Health Equity, situated in an out of nowhere place, believe me. Seeing the throngs of patients waiting quietly, looking at the Rwandan health professionals working alongside the best of doctors and nurses from all over the world, conjured up for me President Obama's quote of the audacity of hope. Professor Paul, there is hope. Please talk to us about that and how we can all reimagine equitable global health, transforming it from, in your own words, a collection of problems to the realm of the possible, even in the most remote, resource-challenged places. What are the prerequisites and the lessons learned? Please go ahead.
Thank you. And thank you, Princess Dina and Philippa, for your kind words about me. You know, that's not a good reason to do this work in medicine, to be praised, but it is very inspiring to me, and I'm very grateful for it. You know, I would just start less in Butaro in Rwanda. I hope we'll get a chance to go back to that. But I will note, before reflecting a little bit on Haiti and on the hope that we can readily see, Butaro, we have had many patients come to us there really because of Philippa. And so that work on elevating our awareness about cancer, learning about it, and I mean us, not the physicians, but everybody, as you said, both of you, is a critical work. The challenge of our work, and I think what's most exciting about the theme that we're launching today, is that there has to be effective diagnosis and care and accompaniment at the end of that referral. So for example, if you went to Butaro just, 15 years ago, well, maybe, 15 years ago, Butaro is a town and it is in a district called Burera, which is a large district by Rwandan standards, 350, 400,000 people. And only 15 years ago, it was pretty much the last district in Rwanda without any hospital at all, any public facility. So that's where we were sent. And we didn't, the first time I saw Butaro was after I had been sent there. And Dina, you know this story, but I'll share it with everyone else. On the top of that mountain, and I was with my great friend, Dr. Agnes Benaguahu, a pediatrician. She was not Minister of Health at the time. She wasn't even the permanent secretary, the main technical position. She was the director of the National AIDS Program, which is both a civil society and a government engagement. But that was, at that point, she was focused on a very narrow area, not on cancer, not but on AIDS. And that meant you had to be focused on tuberculosis, on gender equity, and on what we've called in these materials being launched today, the barriers that the sick face at every turn. On the top of that mountain, which I believe, and I'm almost sure it was the first day she saw it too, because we were looking around, marveling at the beauty of it. On the top of that mountain was no hospital, of course, there was a military base. And, she looked at me and I looked at her and we were saying, this is the most beautiful place we've ever seen on earth, although I haven't been to Petra. And she looked at me and said, you talk to the national leaders and see if you can get them to move the base, which I did. It was gone in 2 weeks, Dina. And then we built the hospital. And then we built the cancer program. And then people that Philippa is counseling to do breast self-exams, for example, or any kind of diagnostic, there's someone to refer to. And that has been the focus of our work for many decades, whether in Malawi or Haiti. The story I wanted to say about hope was it's just an accident for me. There was another earthquake in Haiti, as you know, Dina, and I'm sure Philippa does too. There are lots of ties now between Haiti and Rwanda. So there was another earthquake, and I had occasion to go down to the earthquake zone, which had its usual miseries. Even though the response to the earthquake was a lot more coordinated than the big earthquake 10 years ago, it's still very hard to be in direct contact with that kind of suffering. Children who are crushed, but also who lose their mother and other siblings on one day. But I was shaken by that, as you might imagine. But when I went back up to central Haiti, to the hospital where we launched our cancer care program many, many years ago, I happened to run into someone, a very robust woman, not that much younger than I. But the reason that we're close is because 20 years ago, more than 20 years ago, 25 years ago, she was diagnosed with cervical cancer. And this gets to the heart of the challenge that we're making, really, through UICC and through our various collaborators. What about for those who are already sick with cancer? Cancer prevention doesn't work for them. Cancer control doesn't work for them. It has to be cancer care. So the focus on care is so overdue. Throughout colonial rule on the continent that I know best, there was really very little interest in care, but a great deal of interest in control. Control of populations, control of assets, resources, et cetera, but almost nothing in the way of caregiving. So people like Mabel, Philippa's sister, were living in that, even if they could get on a plane, as she did, they're still living in the clinical desert. And the clinical desert is a place where there isn't the staff, stuff, space, systems, and support that you need to get diagnosed with cancer, much less survive it. So back to Haiti, I saw this woman, and the reason we were friends is because she had had cervical cancer. And it was already too late for her to get a vaccine to prevent it, of course, but it was also too late for local surgical care. She had to have radiation therapy, and there was none in Haiti. And guess what? There is still none in Haiti. So part of our goal is to address this control over care paradigm that is seeped into global health from the very beginning, right? And say, look, we're here about care too, dignified care, expert care. So my friend got the radiation therapy in the Dominican Republic, and my colleagues drove her there, right, across an international border, and went back and forth with her. And then 20 years later, I see her serving victims of the earthquake she was working in the hospital, helping feed people and tend to people and think about little things like, what about this grandmother who lost her glasses in the earthquake? How's she going to be able to see if we don't get her new glasses? That's the kind of caring and caregiving that we need to move front and center if we are going to challenge the powerful, which is because the powerful we want to challenge are not the ones on our side. The powerful we want to challenge are the ones who are saying, look, cancer care is not cost-effective, sustainable, feasible, realistic, even prudent, in settings that are or were recently clinical deserts. And we don't agree with that. You don't agree with that. Philippa doesn't agree with it. And I think that's where we are now. We have to bring the hope that we know should accompany a cancer diagnosis, even the worst ones. Yes. We have to bring that out, roll it out, as they like to say, to people who have been shut out in the clinical desert. And some of those people are not poor people. Yeah. Even middle-class people who are in a clinical desert, still not many of them could get on a plane to get out of the clinical desert. And we've seen again and again in our work how important it is to build local capacity. That means hospitals in places like Butaro, universities in places like Butaro. And I think we're on the right track. And I'm so uplifted myself by the tenor of this, because this is a care over control message that we're getting out. Yes, we believe in cancer control, right? We believe in prevention. With HPV vaccine, that's about clinical cancer. Smoking cessation is another. But we also believe in caregiving for those already afflicted and their family members who suffer a great deal, as Philippa did even before she received her own diagnosis. So I'm very proud, Dina, to be part of this coalition. It means the world to me. I think it is the major challenge, even the major human rights challenge of our times. As inequality mounts, we have so many millions left behind, and we better do the right thing in medicine and drag along the other arenas: education, economic development, health investments make a big difference. And I'm extremely excited about our campaign. Thank you.
Thank you, Dr. Paul. And I think, you've really hit it, you've said it spot on. You've talked about the need to decolonize global health. And you're absolutely right. I mean, the whole Southern Hemisphere has, the whole global health actually conversation. It's always been just to deal about infectious diseases, and as if the people in the Southern Hemisphere or in low middle income countries, they're only busy with infectious diseases because, whether we like to say it or not, because to protect ourselves as well, which is terrible to say, but that's the fact. And then we expect now, after so much, like over a 70-year lag for low middle income countries only gearing up against infectious diseases, to leave them alone to have to deal with laying down the infrastructure for cancer care that you and I know it's very costly and difficult and takes time. But your story, and I think everybody needs to know that, and my story definitely in Jordan, in a medium low resource income country, it can be done. And I think your story with Partners in Health, and especially in Rwanda, your partnership with the government, the fact that the government owned it, they were not just passive recipients of your help. You were real partners in that. And the same with us in Jordan. If we didn't own up to taking on the problem, it wasn't going to happen on its own. So we did our bit to the maximum of what we can do. And we also orchestrated the help that we needed or we didn't need at the time. So that's a very important message for countries who want to follow suit. And also the fact that you've dealt with the barriers to health, the social barriers to health. And that's why you're twinning global health with social medicine. I mean, that's what you're a professor talking about this, is because I've seen it in Jordan when a child who was covered by our foundation for hundreds and thousands of dollars for treatment of his leukemia suddenly stopped coming to the hospital. Why? only because of a $10 taxi ride. And that's when we started our transportation program. And from reading your books and actually visiting your place, you also dealt with that. And your story really is also, I feel, about reimagining, what we already know, changing the way global donor system also works, right? Because sometimes it adds to the problem, even with the best of intentions. Tell us more about that as well. More of the, shall we say, the prerequisites and the lessons learned in your journey of how to actually deliver. If you are going to talk to an audience now and say you can do it, what were the key factors that led you to be able to deliver quality healthcare in an urban setting like in the Butaro district?
Well, let me go right to the specific, Dina, because I was there recently, and including I was there last year for a month at the height of the COVID. Well, I mean, we're not sure what the height of the COVID pandemic is, but it was a very difficult moment. Rwanda had already done a good job, I believe, integrating prevention of COVID and care. And, this is now, as you know, an area of expertise in Rwanda, whereas in the past, in that country as across the continent, the 70-year lag you mentioned is really explained best by the fact that colonial medical systems really did not concern themselves much with care. And as an example of that, you can just go, not to pick on those who colonized that, that country, go to Sierra Leone, where England or Britain had been a colonial power for not for 1 century, but 2. And when they left in the 1960s, they had founded all of 0 medical schools and 0 nursing schools. And they'd also taken the trouble to ban Black doctors from the colonial medical service. So that leaves the views, of the colonial medical, not all of them, of course, there were exceptions, but it tells you a lot about their views about care for the natives. They nonetheless focused on control. And again, the control over care paradigm that we're describing has to be undone in order to decolonize global health. What I saw in Rwanda on that first trip during COVID, I wanted to go immediately. In fact, we talked on the phone, I remember, on that trip. You and I did.
Yes.
I wanted to go across from the university to the hospital to check on the patients. In fact, in my first 5 minutes in the ward, I saw a patient who I recognized from Sierra Leone. In the absence, in a clinical desert, right, and Sierra Leone was still one, is still one, we're trying to address that. If you have a diagnosis of cancer there, which is easier, trying to fly to London or taking them to Rwanda? And that's what had happened. I had nothing to do with it, but I recognized the patient and was very happy that kind of solidarity, South-South, was happening as well. And in any case, I went to the manager of the cancer program, who's not a clinician, who's a great man. You may have met him. His name's Godfrey. And I said, well, what's been happening? Because in Boston, during the COVID crisis, patient after patient with cancer or other chronic afflictions couldn't get their care, even at the greatest teaching hospitals like the one you know best in Boston, right? And its neighbor, where I worked, the Brigham. So we saw it again and again, people stuck away from medical care. And in Rwanda, what they did was to reapportion the vehicles. We have a considerable fleet of vehicles. We have 5,000 employees, all Rwandan practically. And they reapportioned all the vehicles to go bring the cancer care, even chemo, to the patients. And as you know from your visit, they're not all Rwandan. The Rwandans told us, and again, you mentioned this government collaboration. It has been so remarkable. I have worked in a dozen countries over time, and never have we seen this kind of participation and support. In some countries, when you say, hey, we're really concerned about cancer care, they're like, that's not a priority for us. We have to deal with malaria, AIDS, tuberculosis, cholera. We can't be thinking about breast cancer. I never heard that once in Rwanda. Does breast cancer afflict Rwandan women? And we said, yes, we're now discovering it's the #1 cancer diagnosis in women, not cervical cancer, which we were saying for years. And back to the drivers who are led by remarkable people, many of them, and led by remarkable, a former child soldier, actually, they had reapportioned the vehicles and were taking chemo and bringing people back. And of course, they had to have passes to go through all the government checkpoints around COVID. They went to Tanzania, the Congo, Burundi, and Uganda, and every place around Rwanda, they went to deliver that care. So that's the material part of this, Dina. You know, we talk about stigma, but where does stigma come from? If you're living in a clinical desert and you can hardly get a diagnosis, and by the way, many people with breast cancer and any other kind of cancers, they do get diagnoses and then they can't get care. They actually have sometimes multiple biopsy sites, right? And you're like, what happened to your breast beyond breast cancer? They've had multiple biopsies, but still can't get care. So working this out and having at the highest level of our agenda, our international agenda, is critical, because I would say, back to the barriers, all the barriers, the logistic barriers, the transport barriers, the nausea barriers, the management of side effect barriers, the community engagement barriers, all of those can be dealt with. They've been addressed either for cancer or some other thing, right? The biggest barriers we have, I think, is a failure of imagination. Yes. And that's why the third step of this does require us addressing those with any kind of power to say, well, we're only going to focus on cancer control. And we're saying, no, we're going to integrate control and care, because that's the way medicine and public health should always work. And so when you have a head of state saying, oh yeah, we think a hospital on the top of this mountain is more important than a military base, we'll move it. That could be a signal, and it was in this case, as you know, that they're willing to invest in cancer care. And so that one hospital, if I can close with this, that one hospital in Butaro, which is now being enlarged significantly so that it can be the teaching hospital for the university, that hospital, 70% of all the salaries are paid by the Rwandan government. Yeah, we built it, but they run it. They may, and it's just something we should encourage, along with moving away from a control over care paradigm to a caregiving paradigm. We need allies like the Rwandan government and the Rwandan ministry.
But also, Dr. Paul, I mean, we cannot escape the fact that also the type of partnership and commitment that Partners in Health gives, you're not a fly-by partnership. And that is key. A lot of really well-intentioned organizations all over the world, they would just want to tick the box. They come in with their own agenda, own idea, what they want to help, even with the best of intentions. But, they didn't go to the basics, and they didn't intend to stay long. And the fact that you have built a university to start graduating Rwandan doctors and offering it even to the continent, I mean, that's key, and this is something I always say, you want to have the independence to be able to do things. Start making cancer control plan. And I'm sure, every country is able to send a couple of oncologists to be graduates all over the world, etc., to start building the seed. But you've even gone a step further and you've built it in the heart of Africa. And that's really fantastic. To achieve equity is hard work, but like you said, it's the decision to decide that everybody on this earth, deserves cancer control, from prevention to diagnosis to treatment and care. If it's good enough for us in high-income countries, it should be good enough for the rest of the world. So thank you, Dr. Paul, for this. And now I would like to wrap up and to talk about World Cancer Day. World Cancer Day has an important and active role to play in bringing the issue of equity to light on a global scale. World Cancer Day has a message for everyone. It is a day of bearing witness to the millions of cancer sufferers all over the world who have been robbed of their rightful chance for treatment and care. A day to commemorate those who have fought and sadly lost their lives to cancer. A day of agitation and activism, calling out for equity in cancer care. A day for sharing solutions and innovations. And it's also a celebration of progress made and survivorship. But most importantly, it is our day, when we all come together to make the pledge to the cancer community. You are not alone. We are all in this together, and we will not stop until all of us can have the same fighting shot at beating cancer. So please join the movement and start sharing your stories starting November the 4th, 2021. Thank you very much.